along, we have, hold on, let's get to it now. So now we have the labs, right? So with the Mantoux test, like what is the Mantoux test? So again, we said, so this is the anatomy part, right? But in order to know that our lungs is working properly, right, or are working properly, we need to know the normal of when the lab is taken, what it should be, right? And that's why labs are important as well. So when we do the Mantoux test, what we're checking for is for tuberculosis. Okay, we'll learn more about tuberculosis, but very briefly, we know that tuberculosis is a bacterial infection. It's a gram positive, and we'll learn about that. Bacteria that grows, and it doesn't only grow in your lungs, by the way. For those of you who think it's a lung issue, it could grow anywhere. It's opportunistic to the lungs. Like the lungs seem to like it more because there's more. I don't know why it likes the lungs, but it just likes the lungs because it might be more oxygen. Who knows? But it can be anywhere. And what it is it's a bacteria that grows, right? And it won't stop unless it is stopped. And what it does is it's like a pus, right? Like an abscess. And as it grows, it's pressing against whatever part of the organ, in this case, the lung, and it's going to stop the function of that area. And so we need to stop it, right? Again, we'll learn about the medications to take and that in another section. But this test here is testing for the lungs, right? I mean, for tuberculosis. And what it is it's a little bleb that you put right under the skin, which is transdermal, right under the skin. It's a little bleb. And when we look at it, it says upper 1/3 inner surface forearm, right? So I did right here, but it's usually right here, and they'll circle it for you. And so we want it to, so needle bevel up, right? 0.1 milliliters of purified protein, PPD, reading 48 to 72 hours, 2 to 3 days, right? Measure duration, positive if above 10 millimeters. And what that means is, so, don't scratch it, right? Because scratching it will irritate it and that might make it bigger. But once they put it in there, it goes away, right? You'll see the bleb when it first placed, but then it's gone. Now, if you have tuberculosis, it will swell back up and be 10 millimeters. But 10 millimeters are for normal people. When I say normal people, or people who are not immunocompromised, or people who do not have HIV, right? So people who are immunocompromised, HIV means you're immunocompromised. Yours is 5 millimeters, right? That's an exam question. If it's 5 millimeters for those people, they have it. Now, all because it says that this is 10 millimeters does not mean that they necessarily have an active case of tuberculosis. It means that they had it at some point, or that they even had antibodies for it. I mean, like what is it called? I'm not going to remember it right now. BCG. Wow, I did remember it. Vaccine, because they came from a third world country and they vaccinated for them, right? Them for it. But also remember this is an exam question. Now the sputum exam, now that right here, this is, it could be for different things, right? It could be for a person who has, some kind of bacterial infection in their mouth, but it could also be for a person with tuberculosis as well. This is first morning specimen. Also remember, you see, I says first morning. This is something, most examinations that you're going to do, you want to see when they tell you to do it, right? When they tell you to do it, and like the process behind doing it. Like, is it going to be NPO? Is it going to be in the morning? Is it going to be with a full bladder? Is it going to be like, you need to know those little nuances, because they are important. So this one is an early in the morning kind of thing. Approximately 15 mL required, always obtained before initiating antibiotic, right? So this is antibiotic because, let's say this person has thrush, or let's say this person has, what's that thing called? MOM, no, there's an M, something, the kissing disease, I forget the name. But so if this person has a disease that's of the throat, right, of the mouth, then you want to always take a sample first. Now, this is not just with this. This is everything. Every time that a person is suspected to have a bacterial infection, you want to take a sample of whatever it is before you start the antibiotics, right? And that's because, right, we want to know what we're killing. What are we fighting? All right. We that doesn't mean that you're not going to give them an antibiotic. It means you want to find out what the bacteria is so that you can be more specific in which antibiotic you give later on. But you're going to start with what's called a broad spectrum antibiotic because it kills most bacteria. But we don't want to keep giving people broad spectrums because then they become immune to it and their body becomes tolerant of it. So we want to take a sample of whatever it is, find out what the bacteria is, start them on the broad spectrum so it can start fighting. If it works, which is good. But then when the labs come back and they tell us exactly what the bacteria is, then we can go look for the medication that is specific to that bacteria and we can give them that. So that but this test also is in reference to the tuberculosis because I mentioned that the PPD is, it just tells us the person had or might have tuberculosis, but it doesn't tell us if they have it right now. The sputum test tells us that they have it right now because they will take the sputum, they will put it under a microscope, and they will see the positive bacteria. What is it called? I just mentioned it earlier, but they'll see the bacteria growing or moving in the saliva, right? Which tells us this person has an active case of tuberculosis. And that's when you're going to, give them the medication like rifampin and all those other ones that we'll mention later on. Okay, so moving on, we have a thoracentesis. Now, what is thoracentesis? Okay, so we said before that the cavity might become filled with water. If you were in my last class or have already done fluid and electrolytes, I had mentioned that there's a difference between edema and third spacing, right? And what was third spacing? Third spacing was when fluid got into the cavity, right? And so when fluid gets in the cavity, you cannot just remove it just by shifting position like you can in edema, right? Edema, if a pregnant woman, your legs are swollen, lift your hands, leg up. Your arm is swollen, lift your arm up. Whatever is swollen, go move to the opposite side, and it will perfuse or diffuse or shift or whatever with permeability, right? It will move the fluid back into a place where there's less fluid. That does not happen with the cavity because that is called third spacing. With cavities, when fluid gets in there, in order to get the fluid out, you need to aspirate it with a needle. You need to put a needle in there, pull that fluid out, right? And that is what thoracentesis is. Thoracentesis is aspiration of pleural fluid and or air from the pleural cavity. So remember that pleural cavity, the parietal, the pleural cavity. I said parietal is the stomach. The pleural cavity with the visceral and whatever. Well, in the space where there's too much fluid, you're gonna put the needle in there and you're gonna pull it out. But be careful, you cannot pull out more than 1,200 at a time, right? So we're gonna so it needs a consent, right? An explanation. Every procedure that is invasive and it's procedure, like medication is not a procedure, right? It's not a procedure. Anything that's going to have something enter into your body, any foreign object that's other than a medication that's going to enter your body. Well, IVs are kind of, it's not a necessary procedure, but anyway, thoracentesis and other procedures, you need consent, okay? And you need to explain it. A note on consent, just because we're here, consent are taken from the person who's going to do the procedure, right? So your doctor is the person who's going to do procedure. Nurses do not do procedures. That's not your job, right? So whoever's going to do the procedure is the person who gets a consent. Now, you as a nurse will attest, will witness, exam question, will watch the person do the procedure. Watch the person take the consent. Make sure that the consent is done properly, right? The person is not hallucinating. The person is not under medication. The person is old enough. The person is alert, all of that. That's your job to witness and make sure it's done properly, right? But it's not your job to take it. And the reason why is this part right here, explanation. Because when the doctor is asking, can I have your consent for this? The patient will very well say, well, what is this? And what are you going to do to my body? Well, you're not going to be doing it. So you can't explain anything, even though you know what it's about, but that's not your place, right? So know your place. Next, we have a position. So you're going to sit them at the side of the bed with the feet on a chair, leaning over the bedside. So it's going to be like, kind of like this. This kind of expands, this position expands the chest and it gives them room to get in. No more than 1,200 milliliters should be removed at a time. This is just a general thing. Like, so the body has a reaction too much fluid being taken out, and that's called hypovolemic shock, right? And that's fluid, blood, that's whatever fluid, whatever, wherever it is, even though it got there, I don't know how fast, you can only take this much out at a time. And the way that I remember this is, you know, like when you go to the bathroom and you urinate and like you have this like feeling like this, it's like your body's reaction to fluid leaving your body, right? It's like any fluid that leaves your body, it feels it, right? So when you take too much out, it can, you can go into shock, right? Um, so no more than 1200 cc's. That's an exam question. Post procedure, put pressure on the puncture site because it's considered a wound, right? We don't want any blood or whatever to come out. Use semi-Fowler position, that's like half up on the bed. Monitor for shock and pneumothorax. So shock is hypovolemic shock, right? And pneumothorax is by accident we could have injured the the alveoli or the lungs and caused it to kind of recede or kind of start deflating, right? So we want to make sure that that didn't happen. Assess breath sounds. You want to make sure the person is able to breathe regular breaths, deep breaths. Maybe you might give them what's called a spirometer, right? And that's a machine that they put in their mouth and they breathe in and out. You're going to do that for when you give them chest tube to expand pneumothorax, right, as well. Then we have bronchoscopy. Okay, examination of the bronchial tree using bronchoscope. So this is looking into the bronchioles, looking into that area with a device where there's a camera on it and you can see. So maybe if the person has polyps, right, they're like bleeding or whatever, you want to see why that's there. Consent and explanation, it's a procedure. NPO after midnight, before before the procedure, because you don't want them to throw up, right? ABG, oxygen administration. So ABGs, if you also were in my last class or have already done fluid electrolytes, you know ABGs. The next thing after fluid electrolytes is acids and bases. So ABGs, arterial blood gases, what that checks is for the, what is it called? So it checks your oxygen level, it checks the carbon dioxide, it checks the bicarbonate, and it checks the oxygen. So it wants to make sure that optimally you're okay, right? Oxygen administration, you want to give them oxygen. You want to have an embu bag. The embu bag is like the little device that you put on the face and then it has like a thing and then you squeeze it. That's an embu bag. Post procedure, keep a person NPO until gag reflex. This is very important. Anytime you put a person under, anytime you put a person under general anesthesia, you have the first, this exact question for this is remember this, okay? You have to check their gag reflex. And that's because when you put them under, everything, it's a nervous system thing. Everything is depressed, including the swallowing reflex, right? And so you want to make sure that they don't choke and aspirate on their saliva, on the food that they're eating or whatever, and cause other problems later. So anytime a person comes out of general anesthesia, you're going to put one of those tongue depressors in their throat or in their mouth and cause them to go, right? If they do that, we're good, because that means that they won't choke on their food because their body has its own response for that. Monitor vital signs until stable. Assess for respiratory distress. Administer warm saline gargle after gag or reflex returns. Use semi-Fowler position. Give water as first fluid, right? Water is more like innocent, so you don't want to do anything that is toxic or has sugar or anything else in it that it could be more problematic if it lands somewhere else, right, like the lungs. Inform client that it is possible to expectorate some blood, tinge mucus, secretions, especially when a biopsy was performed. So a biopsy, if you don't know, is when you suspect cancer and you want to take out a little piece of it in order to test it under a microscope to see if it is cancerous. And what they're going to do is they're going to see the multiplication rate of that piece, right? And that's going to tell us whether it's cancerous or not. You only see the word biopsy anywhere if there's a cancer involved, right? Or if they're going to check for cancer at least. So that is our coverage of pulmonary or respiratory anatomy. So if there are any questions, I will take them now. Anyone with a question?
Well, I want to say thank you
Sure thing.
for the well explained um, anatomy of the pulmonary. I really learned a lot. It's
I'm glad to.
very, you know, it's a well reviewed. And I just want to say thank you. I did have a question at the beginning. At this time, I didn't write it down, so I forgot. But if I do, I'll probably reach out to you at a later time.
Sure thing. So let me just share really quickly my information. I always forget about that part. Okay, so let me just tell it to you because I let's see if I can pull up my notes and type it. So, are you able to reach out to me? I don't know if you can. If I let me put it in the chat here.
Yes, I can.
You
I
can.
can. I
Okay.
do have your
Okay.
number, and I do have history that you had helped me with my nursing tutoring in the past.
Oh,
So
great.
I do have your number.
Awesome. Awesome.
So thank you. Keep up the good work.
Oh, thank you so much. Thank.
Bless you.
All right. Blessings. Anyone else?
I would just like to thank you for the awesome job there of making it, putting everything into digestible pieces there and lame terms that I can understand. Because this is also helping me there with my father's illness and so forth in terms of understanding various things there. So I have a niece that's ready to go to nursing school, and I'm definitely going to pass on your information. So thank you for the good job that you've done here thus far.
I'm glad to hear that. And it's so good. This information is not just for people who are going to nursing school. I'm glad your niece is, but I'm glad you mentioned like your dad, it helps you with him. And because there's a lot of things that we don't know about our bodies because we didn't study it. So when we have information like this, it kind of helps us open our eyes and our minds and we can understand better what the doctor's talking about, what our parents are going through, what we're going through. And it helps us cope a little bit better when you're better informed. It kind of eases the heart and the mind. So I'm so glad that that was helpful to you. Anyone else? All right. Well, it is 3:10. Again, I will be posting this on YouTube. I'm going to share the post when I do. Do subscribe to the channel so that you can see anything else that I post. I tend to post like terminology and just information. And if there's anything else you guys would like to hear, our next topic, I believe, will be on, I think, psych. I want to like jump into psych next time around. But before then, if you want to reach out, you have my information on Facebook, and I'll put my number in the chat just for those who probably don't. If you, let's see, 917 602 9927. I'm available like all the time. Well, I make time, not all the time, but I make time. So the best way to reach me is via text because I can see what people want at a glance. Voicemails, I discourage people from leaving because that takes a long, oh, even though I have a smartphone and now it types out what you want, which is great. Emails are also welcome. I'll put that also at hotmail.com. But again, you can get me, as I will share again, my website here, right? Uh, right? Facebook here. I have a few people who are reaching out to me. I got to get to them after. Um, the courses that are here. And what else? That's about it. Okay, guys, thank you so much for watching and listening. And do share when it comes out on Facebook because I try to do it live so that if you know someone else who needs help, I'd love to be able to help them as well. Have a great day, everyone. For more information on how to register for classes and get help from our tutoring center, visit www.gab-nicnursingtutor.com. That is www.gabnicnursingtutor.com. To view our free or paid classes, sign up on www.thinkific.com. That's www.thinkific.com and register for the pre-recorded classes of your choice after searching for the Gab-Nic Tutoring Center uploads. We offer in-person tutoring and Zoom calls. You can also find us on YouTube for more free classes and tips on how to do better in nursing. We are also on Facebook, where we upload articles, tips, and tricks on how you can make your journey to becoming a nurse smooth and near effortless. Did I mention Instagram? Basically, we are everywhere. So check us out or call 917 602 9927 and we will tell you just how to join. See you soon!